All right, so glad to have people here. Last Grand Rounds of the year, so we should have some fun, and we'll be surfing. We're going to be riding the waves, in particular, 4 different waves of changes in how we've practiced stroke neurology over the last decade. So disclosures, Genentech, they make thrombolytics like TPA and TNK, and Ischemia is the company that purchased the license for the rapid software that our group developed here. And that was used in 6 of the 16 trials that I'll be reviewing today. So ambitious schedule to review 16 trials. Here are the 16 trials, and they came in 4 different waves. Each wave has a different name, and the breaking news from each of these 4 waves was made in a different iconic city in the United States. So the first one everybody can tell. This was a really shocking revelation in Honolulu, that a treatment that we had been using for a decade did not work. Second wave happened only a few years later in another iconic city, and this one told us the complete opposite, that this was an amazing treatment as long as you met the 3 6s. So what city is that second one? Who can recognize? Nashville. Great news in Nashville. The third wave was our 15 minutes of fame from the Stanford Stroke Center, because 2 studies that used the software that we developed showed that we could shatter that 6-hour time window and multiply it by 4 to a 24-hour time window. What city was that? Los Angeles, yeah. January in 2018 in LA was our big day. And then the current wave has been crashing all year long with 6 trials getting revealed, but the 2 big news New England Journal trials hit earlier this year. What city is that? Yeah, for those of you who watch TV, late night TV in the 80s, you know, it's the big D. So it's how big is too big is what we're going to talk about today. But a quick review of the first 3 waves before the very deep dive into the current wave. So Wipeout happened in 2013 when we were in this gorgeous setting. And every day of the meeting, the news got more and more depressing as one after another randomized trials showed that this treatment that all stroke centers, all comprehensive stroke centers had been using, we'd been using it for over a decade at Stanford, and we were being told it doesn't work. Really, really upsetting news. So by the time I was back to San Francisco, Blue Cross Blue Shield were already saying, we're not going to pay for something that doesn't work. So the whole world of stroke worked hard to figure out what went wrong. And what went wrong was probably poor patient selection, and in particular, the devices that we were using. This first device here, the Mercy device, is very effective with fantastic recanalization rates for wine bottles and good safety. But the success rate was only about 50% for recanalizing blood vessels in the brain, and that sharp tip could cause some trouble. The other device, there were these little vacuum cleaners, the early penumbra device. They could open up clots in the MCA, but oftentimes there'd be debris that would fly downstream. So brain perfusion at the cortical level was not so great. But quickly, these came on the scene, stent retrievers. And the next wave all used stent retrievers, which had much higher recanalization rates and better safety, and produced probably one of the most astonishing findings of neurology in general. This was 5 New England Journal papers on the same topic in 1 year. I don't know if anybody from any other specialty can claim 5 New England Journal papers in 1 year, and they all were winners. Every single one statistically significant on the primary endpoint, showing that this treatment that we said didn't work 2 years ago works really well if you go by the number of the beast, 666. You needed to know those numbers because anybody with an MCA or an ICA occlusion who had an NIH stroke scale of 6 or more, had an aspects of 6 or higher, and was able to be treated within 6 hours, suddenly it was standard of care, level 1A guideline, that you had to treat these patients. And that meant that everybody who saw stroke patients in their ER had to be able to do a quick CTA. That was not being done at the time. Problem with the 6 hours is that most hospitals didn't do thrombectomy. So by the time you figured out you had one of these 666s and you got them to Stanford, it was more than 6 hours. So the next wave was going to focus on shattering that 6-hour time window. And if you looked at these studies, and we've talked about these at previous grand rounds, there's really only 2 of them that used aspects to select patients. The ones that had the biggest treatment benefits and the overall best outcomes used CT perfusion and MR perfusion, used the software that we developed, but everything was positive. So said you didn't have to do that fancier imaging, so let's go to something that everybody can have, which is an aspect score off a non-contrast CT. So that was in the guidelines. But as we moved on to try to shatter the stopwatch, we said, look, if we're going to go out towards 24 hours, let's do the best possible imaging and make sure everybody has a sizable penumbra. So that was done in the 3rd wave, which was January 2018 in LA. It is not too late for most patients. Patients we've been telling for our entire careers, I'm sorry you came in too late, would have loved to treat you if you showed up within 6 hours. Now we could treat up to 24 hours, but they had to have visible and significant penumbra on advanced image with the perfusion imaging, and the core couldn't be too big. We went up to 70 mL. So dead tissue could be up to 70 mL, but not beyond that. And the paradox of these trials was that the treatment effect here was actually substantially bigger than the treatment effects in the 5 previous studies that I showed you that treated patients earlier. So that didn't make a lot of sense to people. How can you treat patients later and get a bigger treatment effect than if you treated them early? After all, time is brain. The sooner, the better. So that late window paradox is a separate lecture. We've given that one before. We won't talk about that today. But if you look at the odds ratio for the shift in the Rankin scale, these were the largest odds ratios. And keep in mind the 2.8 as we look at the large core trials and see what their odds ratios were. For a comparison, our first treatment ever that was shown in 1995 to be effective, IVTPA, had an odds ratio of 1.7. So 2.8 is really good. We like to be at least somewhere close to what TPA does when we think about thrombectomy. But the number needed to treat was incredibly low. And because that number needed to treat was incredibly low, people immediately said, you're over-selecting, right? There's probably a lot of patients that you didn't enroll that could have benefited. And we said, absolutely, that must be true. We tried to find the best patients because we were doing something that people thought was totally crazy, which was going out to 24 hours. Okay, so the 4th wave is the topic of today's grand rounds. How big is too big? Can we bust that aspect 6 rule and bust the core of 70 rule? And does it matter if it's early versus late? And does it matter if you screen with CT or MR? So those were the questions. And these are the studies. And 4 of them have been published in major journals. 2 of them are abstract only. So we don't have the full details on 2 of the 6. But before we dive into these exciting trials, let's take a look at 2 different cases. These are both cases that were treated with large core prior to the large core studies coming out. This one is courtesy of SUNY Upstate, where they saw a 58-year-old woman, wake-up stroke, NIH of 13, not too bad, moderate NIH score. Aspects is good, above 6, favorable, right MCA occlusion, but very large core. So the core is 195, way bigger than 70, but look at the mismatch volume. There's 100 ml of salvageable tissue. So should you treat? Who wants to treat this patient? It's 100 ml of salvageable tissue, core of 195. Well, we'll give you a little more detail. Here's the blood flow and blood volume. And if you're not used to these maps, dark blue means not much happening in terms of blood flow or blood volume. So this area has horrible collaterals. This is almost like a cardiac arrest of this right frontal lobe area. There's no blood getting there. There's no blood flow. So we at Stanford would not have treated this patient. We still wouldn't. I don't think we ever will. But they did in SUNY. And this is a nice TICI 3 reperfusion, beautiful reperfusion in the cath lab. Here's the post-cath scan, which they were originally hoping maybe a lot of that's contrast, but a lot of that's blood. This patient didn't make it. So they came in with a moderate stroke scale and they did not leave the building. So probably was hurt by the procedure. Here's a case that we did do prior to the large core trials. This patient also has 100 ml of mismatch and is a bit over our 70 ml guideline that was in the guidelines and continues in the guidelines. Early window, huge NIH stroke scale, relatively young. Remember the blood flow on the last patient. Here's the blood flow on this patient. Phenomenal collateral. So instead of dark blue, no blood flow, no blood volume into the ischemic hemisphere, we've got dilated vessels doing their best to bring blood flow into this stroke. And if you look at what's diffusion positive, the motor strip is not, right? So there's a lot of very valuable real estate to save here. So this patient went to the cath lab, had a nice operative result with an excellent reperfusion, huge drop from the low 20s down to 6. Unquestionably, we helped this patient. So this large core patient benefited, and rather than a big hematoma, just a little bit of hemorrhagic transformation, which we see all the time in big strokes. So there's a couple of tantalizing cases. And now let's get to the data. Okay, 6 studies. Again, first 4, top 3 published in the New England Journal, the 4th published in Lancet. The other 2 we've just seen in abstract form. So how am I going to review 6 trials in 30 minutes here? We're going to have to chunk them down, break them. We're going to make into 3 sets of 2. So if we look at them, there are, big similarities between sets of 2. The first 2 are MRI studies. We're going to screen with MRI, and we're going to look at early patients. Early patients are highly likely to have penumbra. Penumbra declines over time. So early patients screened with MRI, Japan and France. The next 2 had both non-con CT and CT perfusion, everything for both. China and primarily North America, so Angel and Select 2. And then the last 2, forget the advanced imaging, just non-contrast CT, tension in the US, tension in Germany, Tesla in the US. So if we look at the windows, again, the MRI scans studies early window. The ones that had CTP late window. Remember, if to treat late, the guidelines say you need advanced imaging. So they were looking with advanced imaging late. And then the last 2 that said, forget the advanced imaging, tension, sort of a medium range going out to 12. Tesla went to 24, but I'll give you a preview that it was a negative trial, and within 6 hours, it was clearly positive. So 6-hour positive with CT only, and then a 12-hour, which you'll see was positive with CT only. So let's take these 2 at a time. Before we go into the details, I'll mention that all of the studies looked at aspects in one way or the other. Aspects on an MRI is not going to be the same as a CT because you can see subtle things early, so you'll get a lower aspect score on a MR than a CT. And on a CT, an aspects is tricky, right? So most of these patients in all of these trials came in the aspects 3 to 5 range. But I'll tell you, if you look at an aspects that's scored as 3 or 4, it can look very different than another one that's scored as 3 or 4, because the aspects, you get a point whether there's subtle hypotensity in the region or whether there's severe hypodensity, right? And some aspects regions are small volume and some are high. So you could get a lower score with a lot of small volume regions, or you could get a lower score with a ton of high volume regions. So that's part of the challenge with aspects. And the inter-reader agreement on aspects in these studies was not terrific, as it never is, because we've got the expert panel in row 2, and if I showed them all a case, we'd probably get 4 different aspect scores out of the expert panel. Okay, so then there were 2 of them that used advanced imaging, and the median core volume in these 2 trials was surprisingly low. These are large core trials. And remember, the guidelines at the time these trials were going was that you can treat a core up to 70. The median core was 62 in the Chinese trial. It was 75 in the Select 2 trial. So it means that about half of these patients were potentially patients that we would have already been treating at Stanford. So let's start with the MR trials. And here we're going to have 2 trials that have different opinions or different results. So I have to decide at the end, are you going to believe the Japanese or are you going to believe the French? So these were early window trials. And you can see the big difference here is that the Japanese trial said, we'll look at aspects 3 to 5, sort of moderately large core. And in the French trial, I said, what the hell? We'll take anything. You can have diffusion lesions in all 10 regions of the MCA territory, and you can still get into this trial. Japanese study was pretty clear-cut in what they found. They had some patients who were later. They had a special rule for those. We won't worry about that. It was just a handful. Most of the patients were early window, aspects 3 to 5, and their odds ratio was pretty good. 2.42, statistically a significant shift in the Rankin scale. So more patients in those good 0, 1, 2 ranges. And in particular, if you look at Rankin 5, which is severely disabled in a nursing home, can't do anything for yourself, there's a nice reduction in Rankin 5. So good result of this trial for early window MR selection. What about brain hemorrhages? You're reperfusing patients with big strokes. Brain hemorrhage 9%, symptomatic hemorrhage in the EVT group, about 5% in control. You know, not terrible. And despite the hemorrhages, they did better. So what about more details? Well, more details were provided in their follow-up study in JAMA Neurology that said, wait a minute, it's a 3 to 5 study, but as we look at our data, the benefit is all in 4 to 5. So their quote, EVT is associated with improved outcomes in large vessel occlusive stroke with aspects 4 to 5, but not 3 or less. A few people with less got in as protocol violations. So clear answer. 4 to 5 is a winner, 3 and less is not. Here's the French study. So take a look at this. Here they've got everything going on, including 0s, 1s, 2s, 3s, the ones that the Japanese said don't benefit. So what are you going to predict? This is going to be a disaster, right? This is going to be a whole bunch of patients where the MR is showing a big stroke already on diffusion, and they shouldn't do so well. Here's the surprise. Odds ratio is not phenomenal. It's 1.6, comparable to TPA. Statistically significant and a big benefit in death. Look at the black bars of death, 57 deaths versus 91. Symptomatic intracranial hemorrhage, you'd think this might be a disaster with all these really big strokes. 9.6% versus 6%, not a whole lot different than what the Japanese saw. So are these just little bits of diffusion that we're seeing in these regions? Is the ADC not really low? We don't know. We're going to see all these images. One of the young researchers from this study is going to spend a year at Stanford. He's going to bring all the data, and Martin and Jeremy are going to dig through it and figure out why the French and the Japanese results are so different. But to summarize, early window MR, in Japan, 4 to 5 is a winner. In France, 0 to 5. Okay, let's move on to these trials, which are a little more similar in what they found. So in China, Angel Aspects looked at CT and CTP. Everybody had to have everything. This was our software. Same thing with Select 2, 24-hour window. So most of the patients had an aspects 3 to 5. The asterisk meant that there were some rules that depending on what the CTP core was, the aspects could be much higher in Select 2, and it could be higher or lower in Angel. But most of the patients wound up in 3 to 5. So I mentioned for large core trials, the cores were not particularly gigantic, particularly Angel Aspects, which has the mildest patients likely of all of these trials. So complicated rules to get in. Don't worry about those rules because at the end of the day, most of the patients were aspects 3 to 5, and believe it or not, the core was less than 70. 90% it was less than 100. So these are not really big cores by our CT perfusion criteria. Positive study, statistically significant shift in the Rankin, so better outcomes in endovascular therapy than medical management. No difference in death. There was about a 10% absolute benefit in preventing those really nasty Rankin 5s. And this is the highest rate of 0 to 2. As you look through these trials, you see that the 0 to 2 rate can be pretty low, 10 to 20%. But in this one, it was 30% in the endovascular arm. And again, I think that reflects the fact that there's a lot of patients who would have met diffuse 3 criteria. We would have just been treating these patients during the time of this trial. Hemorrhage rate, twice as high, but not horrible, 6.1 versus about 3% in control. Okay, so that was the New England Journal, but here's the new paper. This just came out a few weeks ago and gives a lot more insight into what was going on in Angel Aspect. So you can see that the vast majority of the patients Had 3 to 5 aspect score and a core less than 70. Right? Again, the guidelines were treat cores less than 70. For those patients, the odds ratio was 1.4 and statistically significant. What if the core is greater than 70 in the Chinese trial? There's a trend, not statistically significant. So it's telling you that the aspects and the CTP core are probably telling you something different. If that CTP core is really big, it's probably concerning. If the CTP core is not huge, we have the benefit. Okay, here's a trial that to me is the most controversial, which is the SELECT-2 trial. And they did something kind of similar to what the Chinese did in Angel Aspect. They had CT perfusion on everybody. So you got to see what the perfusion map looked like, good, bad, or ugly. And you had non-con CT where you made an aspects call in both. They used the software that Stanford had developed for both helping to do the aspect score as well as doing the CT perfusion analysis. And this was a study that was positive, odds ratio 1.5. So not, home run in terms of the odds ratio, but it was statistically significant. And as you can see, if you look at the 0, 1s, 2s, not many patients in these getting to a functionally independent rate, but death, few patients, fewer death, very small difference there, but about a 10% absolute benefit in avoiding that nasty rank and 5, totally disabled outcome. All right, look in red. Something is astray here because as I'll show you, and you've already seen that we're expecting somewhere in the range of a 5 to 10% symptomatic intracranial hemorrhage rate when you do large core EVT. They didn't find any. Nobody was having a symptomatic hemorrhage. Like, amazing, how could this be? I don't know the answer. They did, for some reason, have a lot of vascular injury. But again, despite the vascular injury, which were dissections and ruptures and subarachnoid hemorrhage, the patients did better in the endovascular group. Biggest surprise from the New England Journal article was this table, which said, look, it doesn't matter if your core is small, medium, or large, you all have the same benefit. Particularly odd, if you look at core less than 70, it had the lowest odds ratio. And we'd already shown you from Diffuse 3 and Dawn, cores less than 70 have huge benefit. Whether it was 100, 150, or greater than 150, everybody's benefiting. So this didn't make sense. And there's a reason it didn't make sense is because these were really not the core volumes from CT perfusion. For the patients who had lower core volumes, the PI thought it would be better to look at hypodensity on the non-con CT. This was not part of the statistical analysis plan of this study. It was done post hoc after the data became available. But a lot of this has to do with the fact that we're looking at subtle hypodensity rather than perfusion core volume. So a case like this has a small core, right, 47 ml. So rather than giving the 47 from that table I just saw you, what you actually have is what somebody hand drew of the hypodensity, which again is somewhat subjective and probably would be drawn different by each of our expert panel in the second row. So there was 157 patients who had a CTP core that was less than 70, and actually a quarter of the patients in this trial did not have large core by any measure. They had a CTP core of less than 50. But so what was done in a post hoc way was to let's look at these people with small core, look and see if they have a larger hypodensity volume, and then substitute that for the core volume. So the table I showed you was a hybrid of actual CTP core plus hypodensity core. So for the first time last May in Munich, Dr. Siraj, who's the PI, reported what's the CTP volume response table look like, and it looks very different. It still is favorable, but now you see that a core less than 70 has a very high odds ratio, 1.85, and that greater than 70, it's dropping, but still clearly statistically significant. Less than 100 is 1.98, very favorable. Greater than 100 ml was not statistically significant, but the odds ratio favored benefit at 1.3. And again, at greater than 150, there were only 42 patients. And so you're looking at 20 per group, not statistically significant. There was also a report in New England Journal that no mismatch patients benefited. This was a big surprise to us because no mismatch patients means no penumbra. And sort of the premise of stroke treatment is that we're treating a penumbra. So once we finally got to look at these cases that were reported as having no mismatch, in fact, at least half of them had large mismatches, often over 100 ml. So how could that be? They're called no mismatch. It's that hypodensity measurement again. So if you say how many people actually had no mismatch per the rapid map saying no mismatch, there were 9 in the EVT group. 18 in control, no statistically significant difference. You couldn't possibly have one, even if there was a big one, because there's only 9 in the EVT group. So to summarize, Angel and Select, what they say is CT aspects 3 to 5 and a core up to 70 in Angel clearly benefited. Beyond 70, there was a trend. In Select, up to 100 benefited. Beyond 100, there was a trend. Those were 24-hour trials. Okay, we're going to finish with tension and Tesla. So here we're abandoning advanced imaging. We're just looking at a non-contrast CT, and 3 to 5 is what the vast majority of these patients had. They did go a little bit lower in Tesla. Remember, Tesla is the only one of these trials that was not statistically significant, but it wasn't the 2s that caused the problem. I'll show you what caused the problem in just a moment. But first, we'll start with tension, which is a home run. Of all 6 of these trials, this is the home run. So this is the German trial, aspects 3 to 5, 12-hour window, odds ratio is the best. Okay, the best of the large core trials, 2.58. Symptomatic hemorrhage was 5%, same in both groups. Okay, so no matter how you slice or dice this trial, it looks great. Very positive. Now, a study with a virtually identical study design, except they went longer, out to 24 hours, is Tesla. This one has not been published yet. This one had favorable trends, but was statistically not significant. So will have to be reported as a negative trial. It's the only one of the 6 that's negative. And here is their explanation, which was just presented recently at a meeting at UCLA. What they show is that if you look at the 0 to 6 hour patients, right, patients who very likely have penumbra because they're within 6 hours, there was a nice benefit comparable to what the other studies have shown. But if you look at the patients from 6 to 24 hours, no benefit, and actually some evidence of higher mortality in the endovascular arm. So pretty interesting. So what we have are 2 CT-only trials, one in Germany that looked phenomenal and one in the US that looked good at the 6-hour cut and looked bad beyond 6 hours. All right, so you've just heard a tremendous amount of data. The Rankin 0 to 2 is not the primary outcome for any of these trials, but it's something that we use as a benchmark in a lot of the trials. What this means is the patients are functionally independent and they pretty much go back to doing most of their normal activities, and we're happy with the 0 to 2 outcome. And we can see in general, these patients, they don't do terribly well to get to 0 to 2. The exception is that Angel study. And remember, those had a lot of patients who had a pretty small core and not a huge surprise. And in Diffuse 3, we were looking at about a 45% good outcome rate. Here, we were looking at about 30 in the endovascular arm. Select 2 also had a number of patients with cores that we would have thought are very desirable. They had pretty good outcomes and big treatment benefits. And then you can see the other trials. In general, there's about a 10% absolute increase in getting to 0 to 2. So here's my bottom line. And as you can see, that your bottom line is going to depend on which trial you like the best, because they don't always agree. But for early window, it looks like a CT aspects of 3 or more. And if you like the French trial, you'd say on MR, you can even go lower, that those patients are going to benefit from EVT. And it kind of makes sense that these big core patients probably have a substantial penumbra. If you catch them early, they're going to benefit. In the discussion, we can talk about, well, are there patients in that early window who have no penumbra and shouldn't be treated? That'd be a controversial point at this point. Late window, I still say that the more advanced imaging makes a difference. The patients in these trials virtually all had a mismatch. We have minimal data on what no mismatch would do. We have a lot of previous data that shows no mismatch patients don't benefit from reperfusion. So you could say now that CTP cores up to 100, particularly if you like the Select results, and in some patients even higher, can benefit. So that's a higher threshold than we typically been using before these trials. Overall, as I said, there's a pretty low rate of MRS 0 to 2, the favorable outcomes. It's typically 20% or less. And there's about a 10% increase over control, so that's nice. And there's about a 10% absolute reduction in MRS5. And MRS5 is really bad, so that's nice to have. You can expect about a 4% increase in symptomatic hemorrhage if you treat these patients, but despite that, they do better in the long run. So if we could figure out who's going to get the symptomatic hemorrhages and not treat those, that'd be terrific. We don't know how to do that yet. And then finally, very important for our clinical practice, when we get a call at night to transfer a patient in, the large core patients often don't look like the ones who are in these trials. The ones in these trials had to be completely independent at baseline, no baseline disability. Most of our patients have some baseline disability. And then they had a limited number of elderly. People were nervous about putting very elderly patients in big core trials, and some of the subgroup analysis show that those elderly, are not doing so well. They may still benefit in a shift in the Rankin scale, but their Rankin 0 to 2 or 0 to 3 rates go down to 0. So we have to think about, is that what we want? Do we want to transfer those type of patients in? So lots of things to think about. So tried to finish so that we would have time for a lot of questions and discussion, because this is a controversial topic. But just to review the waves, right? We went from the disastrous thrombectomy does not work and tried really hard to find perfect patients who are going to work. We were able to show benefits at 6 hours for selected patients in 15. By 18, we had shattered the stroke stopwatch for patients with advanced imaging out to 24. And now we get to decide how we're going to interpret the new wave that is still crashing upon us. And we don't have full results from all of these trials yet, but really exciting time for endovascular therapy and stroke neurology to see that we can help so many more patients now than we could a decade ago. Thank you very much.